models of adrenal fatigue, glucose regulation, detoxification, mitochondrial dysfunction, and more. As such, he has been sought out to consult with multiple companies, academic institutions, and wellness organizations. Dr. Walsh is also a board-certified naturopathic doctor and has been seeing patients throughout the U.S. for over a decade. Joining Dr. Walsh tonight will be Dr. Wayne Sedano, our Director of Clinical Support and Education at Evexia Diagnostics. Additionally, Dr. Sedano is the Director of Integrative Medicine Education for the College of Integrative Medicine and lectures and teaches internationally. Before we begin, just a bit of housekeeping. We encourage participation. So if you have a question, you may submit your questions in the questions field in the right-hand area of the interface. We will answer submitted questions towards the end of the presentation. If your questions are not answered this evening, you will surely receive an answer by email within a day or two. In addition, there is also a handouts section that is below the questions that you can feel free to download that and be able to use those slides. So without further delay, I will now turn the webinar over to Dr. Walsh.
Cool, thank you very much. So thank you for being here. Thank you for having me. This is going to be quite long. 2 months ago, we did a webinar about an hour long on oxidative stress, questioning some of the models of oxidative stress, questioning some of the labs of oxidative stress, and then showed how there are a few, very small handful of lab markers on the standard blood chemistry that you can use according to the scientific literature to evaluate oxidative stress. And then the next one, we talked a little bit about different types of anemia, but really kind of dove into a vitamin A deficiency anemia. And then this one is going to be quite a bit longer. I'll probably go for the full 2 hours. I have about 150 slides to get through, although this is a very truncated version of a much larger story, talking about this whole idea of glucose dysregulation. And I submit that there is more glucose dysregulation than we realize. Now, it's epidemic, first of all, in first world countries, but that it's more prevalent than we realize. And that as practitioners, we could be doing a better job in evaluating it, catching it early, seeing some of the subtle differences in different types of glucose dysregulation. And I also think that we're not doing the greatest job when it comes to intervening. And I'm going to show you some really interesting models on that. So that's a lot, really. I realize I said a lot and try to cover the next couple hours. So if you hang in there with me, then hopefully I will deliver. Anyhow, so here's the really, really most important stuff that I could possibly say. I'm a dad of 6 kids, the husband to really, truly a woman that I absolutely don't even deserve, but I feel grateful for every morning when I wake up next to her again. I've been a naturopathic physician for a while. My faith is with God, my heart's with my wife, my dedication's for my kids, and my interest really has to do with peeling back the truths of life, whether it's what it means to be here or what it means to be a husband or a father or a man or any of these things today, and the body and how it works. And could we be doing a better job? Really just trying to uncover truths as much as I possibly can. So the less important stuff, though, is I've been a clinician for a little while. I've been teaching for a little while. And, you know, the next bullet point, I was just reflecting on this. I'm pushing close to about 300 hours of recorded educational content that we've created in the past 15 years, which is a ton when you think about how many hours go into like master's programs. So there's a lot to talk about in the body, a lot of physiology, a lot of biochemistry, a lot of different concepts, a lot of scientific literature to get through. And the thing is you're never quite done, you know, and just when you uncover one paper, you realize how, well, I'm speaking for myself, how dumb you actually are. And how little you actually know, and then that's great because then it's just something to kind of keep looking into. So we do have, my wife and I have a clinical mentorship program called Clinicians Code. The timing of this webinar is actually horrible because we have had the same website for a long time and we're completely overhauling it. It's been about 6 months of intense work, brand new platform, brand new website, brand new branding, brand new everything, and it's coming in like a week. So if you go now, you're going to see an older website that's going to disappear, and but I don't want you to forget. And so if you hang in there for about mid next week, 3rd or the 4th, everything should be there. We're coming out with new courses. I'm going to be working with Evexia, God willing, on some brand new, really cool markers and panels that just aren't being done. But when you look at the literature, they should be. More people should be doing these things. So many exciting things. So anyhow, I'll show you the website later on. You can go, you can sign up, we have your email address to let you know what's going on. But really, it's been great. And I can say this, the testimonials we've had from our mentorship program is humbling. We've really helped a lot of practitioners change how they practice, their happiness, their success in practice, their level of stress, and everything else in this otherwise kind of confusing and overwhelming industry at times. Anyhow, so let's get to the good stuff. So here's the journey we're going to take tonight. In order really to talk about some elements of glucose physiology, we really have to briefly talk about some physiology. Now, that itself could take hours, clearly. In fact, everything that's covered tonight could easily be a 16-hour, 2-day weekend glucose dysregulation workshop seminar. So, but really, it's just about some terminology. If we're going to be talking about certain things that we can be intervening on or assessing, we have to know the terms, so we'll do that. Then I'm going to take a real quick look at some paradigms. And I, for one, think that many times we're wrong about a whole bunch of stuff, and we should be questioning ourselves and what we're doing individually as an industry far more often than we do, because when you look at historically through medicine or science or even functional medicine, nutritional medicine, we've been wrong a whole bunch, and we're quick to kind of shove it under the rug and move on to something else. But I think we really need to look at some of the things that we're doing. Anyhow, we're going to take a look at just a couple markers tonight because that's all we have time with. And if you don't know me or my work, one of my big passions has always been blood chemistry. It's an old test, and sometimes older is better, quite honestly. And I had this idea that some of these quote unquote optimal ranges that have been floating around in the industry weren't really based off of anything. And they're not when you look. And so I've spent a good part of the past decade looking at individual markers, reasons why they're high and low according to the literature, not some sort of made up story about it, as well as optimal reference ranges that are based off the scientific literature, so that you can take them to a doctor and say, listen, someone's medical doctor, say, here's the optimal range for this marker, and here's why. Read through these papers, and then let's have a discussion about it. Anyhow, and then I'm going to take a quick turn and talk about how glucose dysregulation fits into a bigger picture, because one of my theses of this is that if we don't fit, we like to go for the cool, the sexy, the sparkly, the interesting, the modern, the fancy tests, the fancy pathways, the new conditions. But when you consider glucose dysregulation in any of its iterations, so many things that go wrong with the body today have to do with that in the first place. So I bring it back to, we need to be doing a better job of evaluating glucose dysregulation before it becomes a problem, because it's very likely impacting people's hormones, and people will come in for their hormones. They'll talk about a guy doesn't have the same sort of mojo that he used to, or a woman might have PCOS or infertility or some issues, or endometriosis or menopausal issues. Someone might have cognitive issues, or somebody might have cardiovascular, so many things. That's what they'll come in for. But really under the hood is this smoldering fire, sort of subclinical glucose dysregulation. And I'm going to talk a little bit about fatty liver in a way hopefully they haven't seen before. And last, we kind of put it all together and give you some interventions that you can use that hopefully are pretty new, that maybe you haven't seen before. But when you look at the whole presentation in total, will make a lot of sense. All right. Once again, this is a squished, truncated, abbreviated story, or portion, I will say, of a very much larger story. I know I tend to go quickly. You can go back and look at the recording. I'm leaving a whole bunch of stuff out, but I'm trying to give just a little bit of information about a lot of things to show you that there's a bigger story, but also to give you some quick takeaways. All right, so way back when I first started, it's embarrassing to say, but I have, basically like no humility, and I've failed many times in my life. I only used to run fasting glucose, and you may think, well, why did you do that? Well, listen, that's what we were taught to do. Nobody was really running A1C necessarily, and that's all I would run. And if glucose was high, then I would run A1C until a patient brought in her labs, and it was a fasting glucose of 84, but the A1C was above 8. And I was like, oh my gosh, like how many people have I been missing waiting for fasting glucose to go up and then running A1C? And you may think, well, that was dumb. You're right, it was. But I wasn't taught to do this any other way. And so then I ran fasting glucose and A1C on everybody, regardless of how they presented, regardless of their BMI, regardless of anything, just to make sure I wasn't missing anything, until I saw a patient that had normal fasting glucose and a normal A1C, but they had elevated insulin levels. And then I thought, well, man, I really stink, because every single time I think I'm doing a good job, turns out I was missing a lot of things. And here was a case that was presented in our mentorship group. And the woman said, I have somebody who has a fasting glucose of 68. which is a little bit low, but no reported hypoglycemic symptoms, though hypoglycemia is a whole topic. We did an entire workshop on that a long time ago. And an A1C of 4.7, which a lot of people would say is good. I think that's a little bit low, but with a fasting glucose of 6 to 8 is not terribly surprising. However, the c-peptide was 5.27. And this practitioner said, well, here's the reference range. It's 1.1 to 4.4 on LabCorp. So that's a little bit high, is what she said. And so hang on to this. Take a mental snapshot of this really quickly, because what I'm going to show you is this woman has screaming insulin resistance. The reason why her glucose is so low is because her fasting insulin, or c-peptide, which is a superior marker to insulin, is through the roof. 5.27. Can I draw on this yet? Yeah. Sorry, 4.4. I can't believe that that's LabCorp's range. When I show you just a couple of studies, there's a lot of them, but I'll just show you a few. When you look at what an actual reference range should be based on the scientific literature, this is a huge, huge problem, and explains, by the way, the rest of those. So, and again, but what if you didn't have that C-peptide? You'd be like, wow, you have amazing glucose regulation, 68 and 4.7. All right. So let's just go through that journey that I showed you, and we're gonna do a real quick overview. So this does not get any simpler than this. Ready? You ingest food, then your glucose goes up after you eat, then insulin goes up to get rid of the glucose, then glucose drops, then insulin drops after glucose drops because you don't need it anymore, and then assuming that everything's working well, you're done until the next meal or extended fasting. Now I'm going to go into a little bit more than that, but that's just the overall view, right? So in terms of digestion and absorption, when glucose enters circulation, so when somebody eats a meal and it starts to get absorbed, even before that, I should say that you have sensors, if you will, the enteroendocrine cells in the duodenum, will signal that glucose is coming, and the pancreatic beta cells, as you know, can release and synthesize insulin, but they have preformed insulin there in the first place. Okay, so when we eat, we take a bite and we swallow food. I think I'm not going to get into great detail about it, but there's the cephalic phase of eating, and the cephalic is your head. And so the cephalic phase is eating is if you think about food, if you think about it, smell it, sense it in some way, and you start salivating. That's kind of the earliest phases of digestion. When you start salivating, that's just an indication that the rest of your digestive juices are kind of going a little bit. I could sit here and, depending on your proclivity, talk about a big old fat juicy steak, rare, whatever. Some people that'll make you nauseous, sorry, but whatever it is, kale, salmon, that's the first phases of digestion. And it turns out the first phase insulin response is when your body, this is so important, when your body knows that glucose is eventually going to enter into your bloodstream, when it's still in your digestive tract, it releases the preformed insulin that it already had inside the beta cells of the pancreas, ready to go. And it's a really bad analogy, but I always talk about McDonald's. Back in the day, I haven't been there for a while, thankfully, but when you would go and you'd order something, they would turn around and pull it out of the warming rack or whatever, under those heat lamps. It was preformed, it was pre-made. There's pre-made burgers. It wasn't made your way, it was already made. So that's kind of like the beta cell that has a preformed insulin ready to go as soon as glucose enters into your system, your digestive system, and even before it goes into your circulatory system. That's really important. Now I'll show you a graphic that shows you what that does, but that first phase insulin response is so incredibly important because it stops the postprandial glucose surge. It's kind of like priming the system in a way. You don't even need a whole lot of insulin afterwards, but this primes the system for that coming glucose. Anyhow, it suppresses glucagon a little bit, and it begins really, really quickly after you eat something, and then continues for a short window of time, about 10 to 15 minutes in healthy people. Then you have a second phase insulin response, and that's basically if McDonald's runs out of the burgers in the warming area, that they just start making it on demand. So as long as your glucose is elevated, as long as you still need insulin, the second phase insulin response, the beta cells make insulin on demand until you don't need it anymore. And then after the lunch rush, they'll fill up their beta cells again with preformed insulin in preparation for the next meal. Okay, so this is a really cool graphic. It's kind of old. I've done a lot of some of these conversations that I've been doing for a while, but I find that people still need to know it. So in a healthy individual, they eat a meal, here's the meal, and you can see that insulin does this little spike right here. That's the first phase insulin response. And then you look, and then there's just sort of a normal insulin curve, and that the postprandial glucose in yellow doesn't go really high. Now check out this person who has an altered or abnormal or really just a blunted first phase insulin response. So they also eat a meal, and there is no first phase insulin response. Well, look what happens to the yellow hump here. It's quite a bit bigger. So the takeaway is, if you don't have a first phase insulin response, your postprandial glucose goes crazy. And I have a couple slides on this, but I'll say this now, is based on this, that first phase insulin response is thought to be one of the earliest predictors of eventual type 2 diabetes. And it turns out, I'm just going to tell you a whole bunch of stuff now, but that first phase insulin response is stimulated by GLP-1, which I have to say really quickly. So I've been talking about this glucose and GLP-1 and insulin for a number of years now. Probably, I think I did a in-person seminar on this probably about 7 years ago, I believe. And I went on record saying, and there may even be a recording, but I was talking about how amazing GLP-1 was. And when you read about everything that GLP-1 does in the system, endogenously even, that if you could bottle that up as a supplement, everybody would take it. And I had no idea what was coming with all this Ozempic and Wegovy and all these things that are coming out. Amylin agonists, all these things. And I thought, well, it's true. I mean, GLP-1 is kind of amazing. So who knew? Anyhow, so here, this is what I said. The diminished first phase insulin response is one of the earliest, most predictive markers of type 2 diabetes. Now, as a functional medicine practitioner, you want to look at this and say, well, how can we measure that? Because sure, we can look at elevated A1C, and sure, we can look at, even worse, elevated fasting glucose, or how about even an elevated fasting c-peptide? But I'll tell you, at that point, that's already a problem. What we really want is this first phase insulin response. When is it blunted? How can we possibly look at that? So hang tight. You can read through some of the bits and pieces on these slides. Anyhow, it occurs before a significant change in absolute glucose, and it's thought to indicate early beta cell dysfunction. Now, for those of you that get into this kind of stuff, this is the fun part, and there is one clinical pearl here, but don't get too excited about it because it's kind of an extreme case. So here's a beta cell. Now, there's a number of GLUT transporters, right? The 1, 2, 3, and 4 are probably the most popular. 7, 5, there's a couple of them. But GLUT2 are interesting because in the beta cells, glucose just comes and goes as it pleases. It's always open. It's not like GLUT4 that has to go to the cell membrane. It's always open, and it lets glucose in if it's on the outside, which is good because the beta cell needs to know that, right? So glucose enters the cell, you get glycolysis and electron transport chain, all that stuff. ATP goes up. Now ATP, if you notice, and remember, physiologists aren't real exciting when it comes to naming things. So here's this ATP sensitive potassium channel. You could look at that and kind of figure that out. It's a potassium channel. It's going to let potassium in or out, but it's sensitive to ATP. And if you know anything about the sodium potassium pump, there's usually a lot of potassium on the inside of a cell, and this is going somewhere. So when glucose comes in and you start to increase ATP, that starts to block the potassium from leaving this cell. Well, if you know anything about depolarization, repolarization, you get a lot of positive charges on the inside of the beta cell, which then, look at the name, not very creative, voltage gated, because it's going to be a positive charge, calcium channel. So everything turns positive. So more ATP blocks the potassium channel. Potassium stays on the inside. You get a lot of positivity. And then that stimulates the voltage-gated calcium channel. Calcium goes rushing in, and that is what tells insulin to be released. Cool? Okay, so here's the clinical tip on this. If you have somebody that has hypokalemia, which is low potassium, and I'm not talking like functional hypokalemia, it has to be kind of low. If you have somebody that has low potassium, and the only way you'd really pick this up is on a blood chemistry, and it has to be kind of significant. Then you might get, now follow this, you might get someone who has insulin inside the beta cells but isn't releasing it because they don't get adequate depolarization in order to let the calcium in to release it. So that will look like somebody with hyperglycemia, low insulin levels or low c-peptide, and also low potassium. That's just a little tip. You won't see it real often because that's pretty significant. The potassium has to be kind of low at that point. And you may be asking about calcium. If somebody has calcium that's that low, they have bigger problems, so I wouldn't worry about that. All right. So what causes the first phase insulin response? Now listen, I told you, I've been talking about this for a lot of years now, and I will tell you in front of live audiences, and I would say to people, if you were to eat glucose or inject glucose, who would have a higher insulin response? And pretty much across the board, people said that when you inject glucose, you would have a higher insulin response. Why wouldn't you? If you inject glucose straight into the bloodstream, why wouldn't you have a crazy glucose response? Or insulin response. But now people have become more educated on this, and we know that there's these things called incretins. And again, I feel silly talking about GLP-1 now, like I'm on this bandwagon, but I've been doing it for a while. And it turns out researchers thought the same thing. If you injected glucose, insulin would go up higher, but then they found that if you do oral glucose, that insulin goes up even higher. It has a faster and a higher response. And that's because of these gut hormones, things like GLP-1 or the GIP, and that these, when stimulated by food, end up releasing either stimulating insulin and suppressing glucagon, and or just stimulating insulin production before glucose even hits the system, which also makes sense. You eat glucose, your body wants to get ready for it, so it releases these hormones, GLP-1 for example, and that stimulates insulin. So this concept was developed when this was observed. Listen, it's not weird to think this because researchers thought the same thing would happen. So again, I feel really funny talking about GLP-1. I've had this slide for years, and you can see how old this is. So GLP-1 is a whole bunch of things. Everybody probably knows about this now, as it decreases your appetite, a whole bunch of things. It increases insulin. What we're really interested in here is, as the name would suggest, is it decreases gastric emptying. That's why people lose weight on it. Also with the satiety, they also lose weight on it. But here's the big one, is it suppresses glucagon, it increases insulin, and not only does that, it increases insulin sensitivity peripherally. It also increases beta cell proliferation, decreases beta cell apoptosis, which is all a good thing when we're trying to help improve somebody's just overall health and functioning. One of the things that you probably already know about is there's this DPP4. We also have talked a lot about that. I'm not going to get into this a lot right now, but DPP4 degrades GLP-1, okay? So in conventional medicine, they have DPP4 inhibitors. So if you inhibit DPP4, then what you get is more GLP-1, if that makes sense. And one of where you've probably seen this in our industry is, and I don't know if people are still talking about it a lot, but there was a couple companies that came out. It was a supplement, and because DPP4 not only degrades GLP-1, but it also degrades gluten. And so for people that might have had, they have this so-called gluten sensitivity or subclinical celiac or whatever it might be, that they can take this DPP4 supplement in order to break down any what do they call it, accidental gluten exposure. So I don't have a whole lot on this. There's actually a couple papers on this out there. One is it shows that those supplements never even made it past the acidity of the stomach in the first place, so it's questionable if they even worked on gluten at all in the small intestine. However, here's the other thing to strongly consider though. Now think about this deeply for a second. If DPP4 inhibits GLP-1, and if conventional medicine to maximize GLP-1 gives DPP4 inhibitors, that we're actually giving DPP4. So I have this, it's a big question mark. It's not even a suspicion, it's a question mark. That if somebody was to come out with some kind of, like, let's say, enterically coded DPP4 enzyme in order to bypass the stomach and get into the duodenum to break down gluten, you're also breaking down GLP-1. And the long story short is less GLP-1, less first phase insulin response, and then more prone to glucose dysregulation. So if it were me, I'm just going to go ahead and throw it out there. I've never taken DPP4. I don't recommend it. It doesn't seem to work real well based on a couple of studies that I've seen on gluten. However, we want as much GLP-1 as we can get. And if you don't believe that, then look at how popular things like Wegovy are. Anyhow, so food is ingested, incretins are increased, and that increases not only insulin production, but decreases glucagon, increases peripheral insulin sensitivity, delays gastric emptying, and then something else super important is the first phase insulin response, which I just said, okay? And then you get the second phase insulin response. So the rest of the story is about glucagon. I'm going to tell you a little bit about glucagon for those that are interested. And I'm not looking at the comments now. If you guys want to just drop any comments and let me know how things are going, maybe I can take a quick look. Hopefully you're hanging in there. But so when you have low glucose, now check this out, because this is the opposite. And by the way, this is the physiology review. This might be a little heavy for some of you. We're going to lighten it up in just a little bit and talk about some very cool stuff. So just hang tight if this is a little bit heavy. It's important stuff, but like I said, the real cool stuff's coming. This is cool, but the real cool stuff's coming. So let's say you have hypoglycemia, less glucose. Well, the alpha cells that make glucagon, it's kind of the opposite of the beta cells. So when glucose goes down, you get less ATP, and guess what? They have the same ATP sensitive potassium channels, but they work in reverse. So what I'll say is when you have less ATP, then you have less ATP stimulates these potassium channels in order to close. So then you also get a buildup of potassium, and then they also stimulate calcium entry, and it also stimulates glucagon. So kind of cool that it's basically the same machinery, but that they have opposite effects in the presence of high or low glucose, which is exactly what you would want. If glucose was low, you want more glucagon, less insulin. If glucose was high, you want more insulin and less glucagon. So that totally makes sense. That's super cool. Anyhow, just thought you might find that interesting. One of the most important things I could talk about, however, with this physiology review is follow this. Now, this is inside of a pancreas. You have a beta cell here, you have an alpha cell here. So this guy on top is making insulin, and this one on the bottom is going to make glucagon. But check this out, because this is one extra piece that is really cool. So not only does the beta cell release insulin, and these are neighbors, right? So these are living in the pancreas. They're paracrine cells next to each other. So the beta cell releases insulin. Check this out, ready? Insulin binds onto the insulin receptor on the alpha cell. And through a variety of things, this GABA receptor goes to the surface, and then in the presence of chloride, basically can, well, I shouldn't say that. GABA is, let me put it this way, sorry. Insulin is released, binds on the insulin receptor, goes to the alpha cell, the GABA receptor goes to the surface. The beta cell also releases GABA. When GABA binds onto this GABA receptor, then it's a voltage gated receptor. So chloride, which is negatively charged, goes in, and that causes the opposite of depolarization, which is repolarization or hyperpolarization, and that inhibits glucagon. So in a properly functioning, now check this out, in a proper functioning pancreas, the beta cell releases insulin, which tells glucagon, okay, ready? The beta cell releases insulin to tell the alpha cell to not release glucagon, but does so via GABA. Man, that's important. That's super important, okay? And I don't have time to go into that here, but there's some really interesting papers and anecdotal evidence for people that don't make enough insulin, that GABA in some cases might actually help them make more insulin and less glucagon and less hyperglycemia, because I'll show you in a little bit, it may not be so much about insulin, and it has more to do with glucagon. So one more quick concept. Now, there was a trial, it was a 10-year trial that ended in the early 90s right here. Now, I don't know if some of you weren't even born then, and that's fine. Now, I know we talk about like Paleolithic diet and Paleolithic stuff. This is like Paleolithic, because just like think about this for a second. Just think deeply about this. Prior to A1C, what were doctors using to monitor, evaluate, diagnose, and monitor diabetes? And the answer, think about this, the answer was glucose, just straight fasting glucose. They might do the oral glucose tolerance test, but just glucose. That's the marker that they were using. And then there was this 10-year trial that ended in, like I said, the early 90s. And what they call it is the A1C era. Now look at this. When doctors stopped only using glucose as their marker of evaluation and treatment and monitoring type 2 diabetes, and they started to implement A1C, look at the decrease in the effects of myocardial infarction, stroke, amputation, end-stage renal disease. Look at how much those things went down when they started using A1C. So that's why they call it the A1C era. Now I'm showing you that because just to kind of humble ourselves and to say, listen, it wasn't that long ago that all we had was fasting glucose. And now we have A1C, but if history repeats itself, might we be also missing something else kind of big right now? And the answer is yes. And there's two things that I want to talk about this, but it's glucose variability, okay? Now, again, I think fortunately some of this information has been coming out and reaching practitioners in the functional and nutritional medicine space. However, it wasn't that long ago where I would ask a live audience and say, would you rather have chronically elevated glucose or glucose fluctuations? And across the board, because we're told that A1C is bad and chronically elevated glucose is bad, people would say, I'd rather have glucose fluctuations, which is glucose or glycemic variability. But what I want to show you is that fluctuations, those A1C is great. And it looks at, a 3 months of, glucose utilization, if you will. But it turns out that glycemic variability is worse, and I'll show you some papers on this. And again, this is a big topic. You can go into more detail on this, but patients with a similar mean glucose or A1C values can have markedly different daily glucose profiles with different numbers and duration and glucose excursions, which means that they can fluctuate more frequently. They can go up way high and way down. But look at this. So in vitro animal and human studies and experimental settings consistently report a deleterious effect of intermittent high glucose, either larger than or as large as constant high glucose despite less total glucose exposure. You guys follow that? Chronically elevated glucose is bad, but it actually turns out that it's not as bad as major fluctuations in glucose. The more fluctuations there are, even at a lower total glucose load, that's crazy to think about, is actually more deleterious than our chronically elevated glucose levels. In comparison, and here comes GLP-1, long-acting analog insulin, glucagon-like peptide GLP-1 receptor agonist, exenatide, reduces glucose variability in the same reduction with A1C. And you look at this is back in 2009. Here's another one. Look at the title. Oscillating glucose is more deleterious to endothelial function and oxidative stress than average glucose in normal and type 2 diabetic patients. So again, oscillating glucose over a period of 24 hours was more damaging to endothelial function than was, I left this out, stable, constant high glucose. It's better to have stable high glucose than it is to have fluctuations. So as a practitioner, if you're not aware of this, you should be thinking to yourself, well, how can we test fluctuations? Hang in there. Particular attention should be paid to such emerging therapeutic agents, such as GLP-1 agonists. Again, you guys, this is hilarious. Today, this is 2008, that people are talking, I mean, I don't know. It's everything that's going on right now in the weight loss industry with these medications is totally changing the tides and all this stuff. Anyhow, look what they recommend. GLP-1 agonists, pretend that it's GLP-1, or DPP-4 inhibitors to increase GLP-1. So they're saying glycemic variability is bad. And the antidote to this, notice they're not saying it's insulin. This is important. Chronically elevated glucose is bad, but it's not as bad as glycemic variability. Glycemic variability, they're saying, is a lack of GLP-1 incretins. So we need to give more incretins. We need to either, whether it's a medication they're suggesting, or DPP-4 inhibitors. So if glycemic variability is a problem, we need to, one, be able to evaluate it better, and two, have some therapeutic strategies and interventions that we can use in order to help improve this in our patients and clients, ideally without using medications if possible. All right, so we're gonna look at that. So that was a quick dash through physiology, believe it or not. And now we're going to take a look at some paradigms. And this is some of my favorite stuff because I'm totally fine to be wrong, and I have been a lot. And it's very humbling. You know, I think that's one of the most important values that we could have, or characteristics, is just to be humble, to know that we don't know very much. And I think that lends us to be more open to hearing other alternative views, in that we might actually be wrong about things. So let's take a quick look. So have we been wrong before? Well, first of all, we used to think the Earth was flat, and it turns out it's probably not. Pluto was a planet, then it wasn't a planet, then there's some discussion that it would be a planet again. And again, I get really bummed out about that because I was quizzed on that and I said it was a planet. Now, if I was quizzed again, it would be wrong. This is a great one, was the pellagra was thought to be caused by a black fly bite. And well, there's papers on it. There's papers, there's articles. Turns out it wasn't. It was thiamine deficiency. You can, if you have asthma, you can have cigarettes. That's super helpful. Cocaine tooth drops. So again, the question is have we ever been, like, the better question is, have we ever been stupid before? And we have. You know, parasites. You can see that here. Tapeworms. If you're fat, they work. And then one of my favorites was, you know, the phrase blowing smoke up someone's rear end. So that actually came from somewhere. They believed back on the Thames River that they would have these billows, you know, that used to stoke fires with or blow on fires with, that on the Thames River on the boats, that in case somebody were to drown, that they had billows in order to blow smoke up somebody's rear end, because there was a case where supposedly somebody was revived by that. And I've always cracked up because hot embers down there will probably wake just about anybody up. Anyhow, so again, the question is have we been wrong before? You could also say, have we been stupid about things before? And the big answer is yes, all the time. So if we've been wrong in the past, what makes us think we're so right about things now? And if that's not enough, take a look, 1964 Time magazine, talking about the cholesterol is the killer of all, cause of all cardiovascular disease. 1984, cholesterol is bad, and then all of a sudden 1999, cholesterol is good. And not only that, we're supposed to actually eat butter, right? And then if that weren't enough, there's keto, paleo, vegetarian, vegan, Mediterranean, raw, all sorts of different things, and leaving not only patients confused, saying I don't know what to eat anymore, but having practitioners confused as well. And we know this because they ask us too, you know, what are your thoughts on carnivore? What are your thoughts on keto? It's confusing. So have we been wrong before? Let's think about this, however, relating glucose and insulin. Might insulin resistance be an intentional protective measure by the cell? Isn't that weird to think about? If you haven't seen us talk about this stuff before, think about this. Is there any time the body's doing something and you think it's doing intentionally? And there's so many of cases of this that we really should be thinking this more often. For example, somebody in the case of some kind of chronic infection, even a subclinical infection, will become iron deficient inside. The body sequesters iron because the body will feed, or the microbe, I will say, likes the iron for proliferation purposes. So, you know, we might have low cortisol in the case of, again, an infection or cancer, or a variety of things, and low cortisol is normal. It's supposed to be there. It's trying to get more natural killer cells, for example. There's so many examples of this. So might we be looking at this backwards, and that the body is insulin resistant on purpose? It's trying to do this, and we're forcing it and saying, no, you need to take insulin because your glucose is too high. Or we have herbs that basically do the same thing, insulin secretagogues, or they act like insulin or look like insulin. Anyhow, so is that possible? Well, let's look at some papers. Check out this title. Now, this was done in a petri dish, so that will be the first one to say. Insulin resistance is a cellular antioxidant defense mechanism. There we go. So the major advance of this study is that they took 4 different models of insulin resistance, like high cortisol, for example, fatty acid imbalances, too much insulin. And what they said was there was one thing that tied these all together, that insulin resistance, that mitochondrial oxidative stress, superoxide radicals here, were upstream of insulin resistance. And it was the thing that tied these 4 models of insulin resistance together. They went on to say this hypothesis is exciting for a number of reasons. For example, it suggests that insulin resistance may be a protective mechanism in which, and I italicize this, we should perhaps reconsider using therapeutic strategies to overcome unless they eliminate the primary defect. What they're saying is that what if insulin resistance is protective? Then if that's the case, we might revisit our strategies a little bit. Here's another one. This is probably one of the coolest papers on this topic. Insulin resistance as a physiological defense against metabolic stress. You cannot put it any other way. This paper was basically written towards medical doctors saying, what the heck are you doing giving insulin to people who are, their cells are trying to stop glucose from coming in because there's so much metabolic stress going on the inside, which I'll show you in a second, that really should be giving them more insulin and shoving glucose into an already sick cell that's rejecting it on purpose. So here's an example of a healthy cell. I'm not going to go into all these, but here's it might be a skeletal muscle. So here's GLUT4, glucose comes in, turns into pyruvate, citric acid cycle, electron transport chain, increased ATP AMP ratio, a whole bunch of stuff. So you can see, like, under healthy circumstances, you make some glycogen. The endoplasmic reticulum is happy. We make just a little bit of lipid droplets. You get some free fatty acids coming in, and everything's good. That's a happy cell. That's a biochemically that cell that's working well. And you notice here is just a normal amount of insulin in order to kind of stimulate this. Now here's when it goes bad. So this is like you have a party in college. You invite a couple friends over, and everything's going great until they call their friends and they're like, "Hey, so and so's having a rager." And now what you have on the inside, you got all this glucose coming in. And notice what they say up here, aggressive insulin treatment, they're suggesting makes this worse. And there's a couple papers that they had to stop early, a couple trials they had to stop early because aggressive glucose lowering in type 2 diabetics had bad consequences. People were dying and getting more sick. And so this is the thought behind it. So anyhow, look, so now instead of just a little bit of glycogen, you get excess glycogen, but you get the spillover in the cytosol to things like polyols, like sorbitol and erythritol and some other hexosamines. You get reactive oxygen species mitochondrial dysfunction. You get endoplasmic reticulum stress. You get these massive accumulation of ceramides, for example, and then you get inflammation. And so their whole premise of this was, let me just go back to the title, insulin resistance is on purpose Because, oops, went backwards too far. Because when this is happening here, if that, okay, so let's go back to the raging party in college. What do? You tell everybody, listen, I can't let anybody else in. This is, until I get this mess cleaned up, I'm not letting I'm closing the doors, I'm locking the doors. Nobody else is coming in right now. And so what they're saying is the body is insulin resistant on purpose so that you don't get more glucose coming in to your already crazy party that got way out of control. And my question to you as a practitioner again is, when you look at this, then what do you start thinking? Well, okay, well, how would I deal with that internal stuff? How would I get rid of the bad players in this party so that I can let people back? I can start letting glucose back in. All right, so might we be wrong? Yes, it turns out that. But what if insulin's primary role was not to get glucose into cells? Sheesh, that would be a big one, wouldn't it? So this is a really cool paper because, well, I'll just kind of give you a summary of this. One of the things this paper talked about was, and this is an older paper, is that a lot of times when they were using exogenous insulin in studies, it was in a non-physiological dose. And they said, well, let's do a physiological dose of insulin in a constant steady state and see what happens. And they did it in healthy people and in diabetics. And check this out. This is kind of fascinating. I might slow down a little bit. So the effects of continuous insulin infusion in physiologic doses, guys, that's a big part of this one, on glucose kinetics and circulating counter-regulatory hormones. Which, okay, now here's what they did. You can read this. I'll kind of talk you through it. So just think about this. You get a needle in you, and it's a steady supply of physiological dose of insulin. What would you expect to happen to glucose? It's going to go down, okay? Now that makes sense, and that's what they saw. So in the healthy people, it fell at a rate of, not that it's important, 0.37 milligrams per minute for 75 minutes, and then it stabilized at around 67. Now what that means is insulin was lowering glucose and it got a little bit too low, and then it stabilized because the counter-regulatory hormones would kick in to try to keep it at that level. Otherwise, it's going to keep dropping. But here, remember what the question was? What was my question? What if insulin's primary role is not to get glucose into cells? Okay, well, let's look at how this changed. This is huge. Ready? The changes in plasma glucose were entirely a result of fall in glucose output, whereas glucose uptake remained unchanged. What does that say? Glucose dropped, not because it was being disposed of by insulin at a physiological dose, but because it slowed down hepatic output of glucose. I'll say that one more time. Like, this should be like kind of mind-blowing, I think. It is to me. Is a steady supply of physiologic dose of insulin, lowered glucose, stabilized at a certain point, but it's not because it got rid of it like we're told, but rather it was because it slowed down hepatic output of it. Wow. So they went on to do the same thing with diabetics, and guess what? The initial fall, the same thing happened. The initial fall of plasma glucose was almost entirely a result of suppression of glucose output, okay? And they went down too. In contrast, the late stabilization was a result of a fall in glucose uptake. So they had less glucose uptake with this physiologic dose of insulin. So does insulin really get glucose into cells? I don't know. It's highly questionable, because there is something, and I think it says it here. Yep, there's something called non-insulin mediated glucose uptake is what this says. And they conclude in this particular paper that this, just listen to that phrase, non-insulin mediated glucose uptake. That is glucose getting taken up into cells like skeletal muscle, like fatty acids or adipocytes, and it's not mediated by insulin. Non-insulin mediated glucose uptake is the major pathway for glucose disposal in controls, healthy people, and non-insulin diabetics, dependent diabetics. For given glucose level, the efficiency of this is equal in both groups. But since basal glucose, I don't know why RD is glucose, is elevated in people with diabetes, their absolute basal rates of this are higher. That means that they get rid of more, guys, they get rid of more glucose just because they have so darn much without any insulin needed. And then that brings up this again. And if we are trying to shove more, let's dispose of more glucose. I don't care if it's fenugreek or injecting insulin. If it has to do with insulin, maybe the body doesn't want more because it's already causing so many problems. Anyhow, so might insulin resistance be protective? It's possible. maybe insulin's job is not to get glucose into cells necessarily, and we saw that perhaps its job is to slow down hepatic output. That's weird. But what if something else was responsible for hyperglycemia? Okay, are you ready? Actually, I'm going to take my first sip because this is too cool. All right, so this was the first study of 2. This is the lead author here, this Unger guy. This is so stinking amazing. I could basically just, if you haven't seen the study, just cover these 2 studies and just leave. And like, you know, it's so cool, so cool. All right, so I'll kind of set this up. So imagine, so it was done in mice, not humans, but you're not going to get humans to be able to do this one. So imagine, what is the fasting glucose of somebody with type 1 diabetes? They're not medicated, not insulin, they're not medicated, nothing. So a type 1 diabetic has 0 insulin, and therefore their glucose is through the roof, you know, 300s, 400s fasting glucose. Their oral glucose tolerance test, they do horribly on it as well. Now, what this researcher did was he took these mice, there's a couple different types of mice. One of the groups of mice had, and this one's you might have to go back and look at this recording, had glucagon receptor knockout mice. That means they didn't have glucagon receptors. They had glucagon, but they didn't have glucagon receptors. So effectively, they didn't have glucagon because whatever they had didn't work, because they had nothing to receive it, nothing to stimulate on the back end of the cells when glucagon was present. Okay, so they had regular mice, and they had mice that didn't have glucagon receptors. Now, it's really unfortunate that the lab mice get so many things done to them, but they can induce type 1 diabetes in mice by giving them an injection of something called streptozotocin. And when they do that, it wipes out their beta cells, and they effectively give these mice type 1 diabetes. Now, check this out, because these 2 papers are mind-blowingly amazing in my opinion. Okay, now in this C here, both of these mice, the squares and the circles, have type 1 diabetes. Notice, there's weeks after the streptozotocin injection. They both have type 1 diabetes. Look at their glucose level. First of all, notice that their fasting glucose is around humans, right? It's around 100. But check this out. So who is this in the circles? Those are normal mice who got type 1 diabetes. And that is exactly what you would expect to see, is the glucose goes crazy. But who are these guys? These are, listen to me super closely, please, type 1 diabetic mice who don't have glucagon receptors. Now, I'll just do the too long didn't read thing. Basically, the premise is the job of insulin is to suppress glucagon. And if you don't have insulin, glucagon goes nuts. So in type 1 diabetics, if they were to measure glucagon, which is a difficult marker to run, it's expensive and it's not run very often, it's usually done for research purposes, but if it were run, it'd be through the roof in type 1 diabetics and late stage type 2 diabetics. And listen, what is the role of glucagon? To stimulate glucose production. So in people that you see crazy hyperglycemia, is it a lack of insulin, or is it really too much glucagon? And people think it's a lack of insulin and you can't dispose of it and it's not getting glucose into cells and all these things. But really, insulin's job might be to suppress glucagon, because glucagon's job is to increase glucose. And these mice here effectively didn't have glucagon because they had no receptors for it. And check out, again, I'll say this again, those white squares are type 1 diabetic mice with totally, they have no insulin. And by the way, here's their insulin levels. Okay, they proved that they had no insulin. It wasn't like, well, or maybe they're making some. No, they're not. They proved it. They're not making insulin. But they have totally normal glycemia, type 1 diabetics. Not possible, right? But they had no glucagon receptors. That's nuts. And they actually have the same oral glucose tolerance test results, which if it was a type 1 diabetic would not happen. All right, so they redid the study again. So here's that same awesome guy. Did the same thing. You guys look at normal mice after beta cell destruction and knockout, the glucagon receptor knockout mice. They did it again, same story. You can see here, they looked at insulin levels. They were making no insulin. They proved it. The other mice were started to, but then weren't. And then over here, they had the same glucose levels. You couldn't tell them apart. Okay. So anyhow, so they said, and check out the title of this: glucagonocentric restructuring of diabetes. Basically saying, let's stop talking about insulin, folks, and let's start talking about glucagon. Okay. And now this is super important to discuss. and just to show you some, this is important. Okay. So this is the pancreatic islet cells inside the pancreas. That's the neighboring alpha cells and beta cells. Now, what I really want to show you here, and this is where things get a little bit wonky, is the amount of insulin inside the pancreas. Remember when I showed you those two cells right next to each other, and the insulin, the beta cell was releasing insulin, and it handed it off to its neighbor who was asking for a cup of sugar, the alpha cell. And when that happened, GABA came across, and the chloride went in, and it hyperpolarized it, and that restricted glucagon. The levels of insulin inside the pancreas are through the roof. That's 200 microunits per milliliter, tons of it. Now, and that's where it's made, so that would make sense. But by the time it gets to the liver, it's only about 60 microunits per milliliter. But then when it finally gets to the periphery, it's only 20. Now, what do we do in medicine to try to get more insulin? Well, we're going to try to mimic the amount that does it at the periphery. If you try to give any more than that, you'll kill somebody, right, in the periphery. If we could get it in deeper, then that'd be different. But so we're mimicking, and now look what happens. Look at the glucagon level in this person. But that's because you have this huge amount of insulin here progressively getting lower, and this is how much we see in the periphery. But in medicine, when we inject it, we're only doing the periphery level, and look how high glucagon is. That is the problem. We're giving insulin in these doses that are fine peripherally, but it's not doing anything inside the pancreas or even in the liver, where you're supposed to slow down glucagon's effects on gluconeogenesis. But this is why we have that hyperglycemia. So anyhow, and this is just to show you that glucagon and glucagon receptor agonists, they're considering these things, but they can't find anything that really works yet. Okay, so this is in medicine, but I come back to this question of, might we be wrong? What else if there was some, is it low insulin or is it high glucagon? And the last question I have is, what if insulin resistance is intentional and therefore beneficial by the body? And there's a lot of papers on this. I only have time to show you a couple, but listen to this. And guys, I hope you're enjoying this. I really, truly do. I hope you're feeling like frustrated, like, oh my gosh, how come we don't know all this stuff? Or maybe you already knew all this stuff, and that's fantastic. But then kind of excited, like, gosh, there's so much to learn. There's so much we can improve on. You know, I'm just giving everybody my same, glucose lowering protocol. And maybe it's working. Listen, insulin works on people too, but maybe we could be doing something better. So I hope you're excited and that this engages you. Okay, so look at this: stress hyperglycemia, and they even use an exclamation mark. An essential survival response. Look at this. I'm just going to read this. This is so good. And they always go end case scenario, like sepsis, somebody's in the hospital. But you got to peel that back a little bit and say, all right, well, what about subclinical infections? Maybe it's subclinical sepsis. Maybe somebody has a chronic infection that they're not really aware of, or maybe they have a stress that's not bad enough to send them off to the hospital. So read this: stress hyperglycemia, high glucose due to stress, is, gosh, this is so good, you guys, is common in critically ill patients and appears to be a marker of disease severity. Now, if I just stop there, what will doctors do? Usually they'll try to lower it, right? Oh, glucose is too high, let's lower it. Bad idea. Furthermore, both the admission as well as the mean glucose level during the hospital stay is strongly associated with patient outcomes. Look at this. A critical appraisal of the literature has demonstrated that attempts at tight glycemic control in the ICU and non-ICU patients do not improve healthcare outcomes. So once again, I said how we've done stupid things before. So it makes sense. Patient comes in, they have hyperglycemia. I'm a doctor. I say that's too high. We got to lower it. But you know what? It doesn't improve things. Maybe it's on purpose. And I say that because if you have a patient that has hyperglycemia, what a different process it would be when they came in and you're like, I wonder why the body's doing this. Not just that somebody's overweight and they're just watching a bunch of like Steel Magnolias reruns or whatever, or This Is Us, or eating Ben and Jerry's and Ding Dongs and Ho Hos, and maybe there's something else going on, and we need to think about these things. We suggest that hyperglycemia and insulin resistance in the setting of acute illness is an evolutionarily preserved adaptive response. Read that again. It's an evolutionarily preserved adaptive response that increases the host's chance for survival. What does that say? Hyperglycemia in certain situations will keep you alive longer than someone that can't. Man. Furthermore, attempts to interfere with this exceedingly complex multi-system adaptive response may be harmful. Don't screw around with this. Don't give iron to somebody that has an infection. You're going to make them worse. Oh, you have anemia. I need to give you iron. No, you don't. The body's doing it on purpose. Like, again, you guys, Practicing is fun. It's not easy. It's not. We have to actually use our brain and think. We have to use the latest research and look at the markers that can tell us if somebody has an infection or not, and whether the body really wants iron or not, and not give it when it's not supposed to and give it when it's supposed to. And in this case here is, again, not just see high glycemia and say like, oh, here's berberine, but rather think about this and say like, is there something going on in this person's life that maybe they're perceiving this and actually it's going to be harmful if we try to adjust this. Man, that's huge. They go on to say, following thermal injuries, trauma and sepsis, non-insulin mediated glucose uptake is increased. We already looked at that non-insulin mediated glucose uptake. The majority of the increased glucose uptake occurs in macrophages rich tissues. Well, that would make sense, especially if there's inflammation going on. Iatrogenic, doctor-induced, normalization of blood glucose may therefore impair immune and cerebral function at a time of crisis. You guys follow that? There's papers upon papers among papers on this, that insulin resistance kept us alive. It kept glucose from going into cells and maybe going into our brain during periods when we actually had to think and get out of a crisis, or fuel our immune system, fuel the macrophages like you just saw. Anyhow, so one more, evolutionary benefit of insulin resistance. You don't get a title that says it better than that. Here we hypothesize that insulin resistance promotes glucose availability for the inflammatory response. How can we see glucose and hyperglycemia and the inflammatory response at the same time? Is it maybe that the inflammatory response came first and hyperglycemia came second, and it's trying to fuel the immune system so that you can have an inflammatory response against whatever perceived threat there is by the body? In the defense against starvation, disease, and trauma, and to promote growth during lactation, pregnancy, puberty, and cancer, and in situations where the organism prepares itself for migration or hibernation. Fascinating. This mechanism is evolutionarily well preserved in multiple species, including the human organism. It is also likely that in other insulin-resistant states like chronic inflammatory diseases, and they name a few, insulin resistance is initially beneficial in promoting the inflammatory response and healing, you guys. So back to my questions in a second. This beneficial role of insulin resistance has consequences, you guys, and this is where it all comes together. Treatment and research. Forcing glucose into, and this goes back to that crazy party picture, forcing glucose into oxidative pathways by liberal administration of insulin deprives an organism of glucose for synthetic and antioxidative pathways, which is actually suggests by recent findings showing that ICU patients' late initiation of parenteral nutrition was associated with lower insulin infusion rates, faster recovery, and fewer complications. Man. So once again, have we been wrong before? So based on that, I have some questions. So which of our patients have insulin resistance as a protective mechanism? And it's intentional. I'll tell you, PCOS, there's a strong indication that that insulin resistance was evolutionarily helpful in times of lack of food, for example, and reproduce. You don't want to make more babies if the environment's not safe or there's like a lack of food. So in your PCOS patients who have insulin resistance, you want to look at this and say, is there something in their environment that they don't feel safe about? And that's an entirely different discussion than giving them myo-inositol, for example. What came first, inflammation or insulin resistance? What are the consequences of focusing on glucose and trying to lower them as a primary goal, or A1C, like I said, or fasting glucose, or whatever markers it is, and only using that as our guide? You guys, I told you, trials have been stopped early by too aggressively going after fasting glucose and A1C. And I know very well there are functional medicine practices that teach other ones, and they have very aggressive glucose lowering strategies, and they use natural stuff, but I have huge concerns about that. I've watched labs get worse in some of these patients. Anyhow, how would a change of practice and focus if hyperglycemia was caused by high glucagon and not insulin? All right, we're about an hour into this. Hopefully you guys are doing well. I know I'm going quickly. A lot of good information here. Let's see, we are still rolling along. Insulin resistance, as a summary so far, might be protective at the cellular and systemic level, trying to preserve cell function and allow glucose to be available for other tissues during infection, inflammation, and stress physiology. Hyperglycemia may be a consequence of hepatic overproduction based on high glucagon, rather than poor disposal at the periphery used by insulin. And lastly, hypoglycemic agents do work. You guys, I'll say straight up, berberine, fenugreek, bitter melon, vanadium, you name it, any gymnema, all of those historic herbs, vanadium's an herb, they'll lower glucose. They absolutely will. But the question becomes, by what mechanism? And if we're doing more harm than good. So this is a long story. I told you we're on a journey here. So let's visit that journey. So we just did a critical look at some paradigms. Now I want to talk about two particular markers. There's a whole bunch that we could do, but clearly there's not enough time for that. Then I'm going to talk about fatty liver in ways that hopefully stimulate your desire to try to look for fatty liver better in your patients. Because once again, what are the symptoms of hyperglycemia? Until it's really high, there are none. And somebody has a lot of silent symptoms. And then as I will show you, what are the symptoms of fatty liver? It's not liver. I'm going to show you it's things like pain, anxiety, depression, and a whole bunch of things that we are there for. If someone has anxiety, what do we do? Give them GABA. If someone has depression, what do we do? Give them serotonin or tryptophan. If somebody has pain, what do we do? Give them like PEA or bromelain or something. But my point is there's a lot of silent symptoms going on under the hood that are related back to glucose dysregulation, which goes back to my very first thesis, and that is we need to be doing a better job using the tools and the literature that we have available to evaluate, and I'll show you in a second towards the end, and putting it together how to help these patients better. So hopefully you guys are doing well. I'm just going to keep on going. All right, so I have a few slides here. I'm just going to summarize this if I may. The reference range is the most critical part of a laboratory test, period, hands down. That's all there is to say about it. Okay, you can argue for certain markers, but a marker is only good as its reference range. If the reference range is not accurate, then you're going to miss a diagnosis. And so therefore, it is the most critical part. It tells you if you're going to intervene or not, if something's abnormal or not, if they're going to get a diagnosis or not. So the reference range is of critical importance. Some of you probably know this, but the way that it comes, I might show you the next one. Basically, here's how they get it, is they take a group of people, they look at the highs and the lows, they do usually plus or minus 2 standard deviations from the mean, and then that's where you get the range from. So for example, this is usually, most labs will have a potassium around here, 3.5 to 5.0, but labs will vary, which should give you pause also. And so that's basically where they get the ranges from, is a Gaussian curve, and so they do these things, okay? So there's a bunch of markers we can look at when it comes to glucose regulation, and I don't have time clearly to get into all these. I've already taken about an hour so far. So I'm really just going to cover the two that I think are really important. Most people know about fasting glucose. Non-fasting glucose is a very interesting subject, and we have a couple really cool papers on this and what non-fasting glucose should be. So at any time, somebody can walk into your office. It doesn't matter if they ate or didn't eat, or what they ate. You can do a finger prick test and get a fasting glucose and have a pretty good idea of where it should be in a healthy situation. Again, regardless of what they ate. A1C, a lot of people know about, but I want to talk about c-peptide because it's a surrogate marker for insulin, and I want to talk about this glycomark, the 1,5-N-hydroglycerol. More people know about this now, but still it's a very good marker to know about. So check this out. I showed this to you once, but LabCorp has a reference range for a c-peptide of 1.1 to 4.4, and that's what I went by for a while until I started looking into the ranges. So just so you know what c-peptide is, so remember when I said that inside the beta cell there's preformed insulin? Well, this is basically preformed insulin. This is like pre-proinsulin is what it's called. And you can see here this yellow chain is c-peptide. It has these little bonds here that when insulin is released out of the beta cells, this gets cleaved off right here. And what you get is you get a molecule of insulin and you get a molecule of c-peptide. You get the red one and you get the yellow one. Now, why is c-peptide a superior marker? Insulin has a half-life of minutes, let's say 4 to 7 minutes. C-peptide has a half-life of about 30 minutes. That's because the liver metabolizes insulin, but it doesn't metabolize C-peptides. So it exists longer. It's a longer, more stable marker when looking at insulin. It's produced in equal molar amounts. So the same when you look at C-peptide, in most cases, unless there's something weird going on like antibodies, C-peptide is a surrogate marker for insulin. It's more stable. It's more accurate. There's a bunch of papers that say that. I know everybody's running insulin. Insulin's a less expensive marker, but I'm telling you, C-peptide's a little better. I will go ahead and just say, if you can run both, run both. I have reasons for it. There's some calculations that use insulin. There's other calculations that use C-peptide. I personally think both should be on a lab, but I don't have time to go into that. So it has a longer half-life, 30 minutes compared to about 4. The pharmacokinetics of C-peptide have been well studied. In fact, there might be some metabolic activity to C-peptide, and I just go back and say, have we been wrong before? We have been, so we might still learn more about C-peptide. So when looking at an optimal reference range, I'm just going to show you a couple of papers, though there are more. So this is looking at fasting serum C-peptide levels to predict cardiovascular and overall death in non-diabetic adults. It's kind of important. So look what it says. C-peptide was superior to other insulin-derived measures of insulin resistance in predicting cardiovascular and overall death in non-diabetic adults. C-peptide, ready, predicted cardiovascular death even in subjects with normal glycemia and without metabolic syndrome. Why are we not running C-peptide on everybody? Prospective studies are needed to look into this a little bit more. These results would support that the increased risk of cardiovascular death in subjects with high C-peptide levels is unlikely to be attributed solely to the eventual development of diabetes and suggests additional or alternative mechanisms of harm, like, for example, maybe insulin resistance and maybe intracellular metabolic stress, like that party picture that I showed you. But here's what I wanted to show you, because really what we're trying to do is find a good reference range. Now, these were done in the international units. So when you look at the C-peptide levels here, that doesn't look like 1.1 to 4.4 to me. That's fine. So I've calculated those for you. And here are the ranges. Now, you guys, now this gets, I mean, I don't know if you've ever questioned yourself so deeply that you're sure you were wrong. Like, what am I missing? The LabCorp range was 1.1 to 4.4, right? And I was looking at this and a whole bunch of other papers. What I want to show you is, really, you can kind of cut it off here. When C-peptide starts to go even close to 2, 1.9, look at the history of the stroke goes up, history of heart attack goes up quite a bit, chest pain goes up, all these things go up. Fasting glucose isn't too much higher. These are all statistically significant, but that wasn't all. Check out this. I think I popped it in here too. Yeah. So look at this. Once it goes above 2, look at the hazard ratio for cardiovascular mortality. Now, 1.6 isn't anything to ignore. Same deal, cerebrovascular, ischemic heart disease, you know, so this is, they went up kind of a lot, which is, if you ever look at a study like this, you want to say, well, first and foremost, where would I like my C-peptide to be? And clearly, down here near the referent would probably be one of the best spots, because these hazard ratios do start to go up a little bit. Okay, so here's another paper. We found association between serum C-peptide and all-cause and cause-specific mortality among adults without diabetes at baseline. Our findings suggest that elevated C-peptide levels may be a predictor of death. Another one was showing this paper was showing the specific units, and I just want to kind of show you this here once I get down to, here we go. So here they use international units, but check this out. So this is the different groups of C-peptide that they used here. And what they had to show you is anything above this one here, which is only 3.6, had a 1.8 to 3.2 fold increase of all cause and cause-specific mortality compared to those that had a lower C-peptide. So that 4.4 is way too high. Let's continue. I'm just showing you. I've looked at a lot of papers. This is just a smattering of them. You know, it's what I do. I try to find a truly optimal reference range based on the scientific literature, that if anybody questioned you, the Surgeon General could question you, and you can show them these papers, let them read through them, and then say, this is why I have the reference range that I do. Okay, so fasting C-peptide levels and death resulting from all-cause and breast cancer. There's another paper, cognitive decline. You guys see, peptide should be run on every panel. C-peptide levels are not significantly different between insulin resistance and non-insulin resistant type 2 diabetics, but among healthy subjects, they are higher in those with insulin resistance. Okay, and once again, so check it out. So here's the control subjects. Here's the type 2 diabetics. Here, check, this is so good. Control subjects with insulin resistance, non-insulin resistance, and then type 1 diabetics. Listen, so their C-peptide wasn't all that high. Well, if you have type 2 diabetics, they're probably going to stop making as much C-peptide, but check this out. Look at the C-peptide in healthy people without insulin resistance versus the ones with insulin resistance. So I'm asking you, what do you think is a good upper level of C-peptide based on these couple of papers that we looked at? And there's more. It shouldn't, in my humble opinion, go above 2.0 at all under any circumstances, and that's starting to look at too high. So the traditional range is about 1.1 to 4.4, depending on the lab. The optimal range, I will tell you, based on these papers and many others, I don't think it should go much above 1.8 nanograms per liter, okay, milliliter. The second marker I want to talk about real quickly, I'm going to take my second sip here if you don't mind, is glycomark, also known as 1,5-anhydroglycitol. When I first started talking about this, we did well, my family and I bought an RV and went on a 9-month trip to do weekend seminars in functional medicine and blood chemistry interpretation all around the US. We even got into the UK for a quick one too. Crazy trip before COVID. It was kind of awesome. Might do it again. Anyhow, but when I would ask these audiences of 40 or 50 people in each of these locations, has anybody heard of glycomark? Nobody had heard of it. The only time they'd heard of it was because I had talked about it before. Now, it's not a perfect marker, but it's pretty good, and I'll explain it to you. So this 1,5-anhydroglycitol. So this is showing you this glycemic triad. Fasting glucose has its values. A1C has its values. C-peptide, I think I showed you, has its value. But this is really interesting because I'll explain it to you. Glycomark is, ready, a marker of postprandial glucose levels. Now when I first read this, I thought, what in the heck? How could you possibly evaluate postprandial glucose levels in a fasting blood marker? It didn't make sense. But when you look at the physiology and you really dive deeply into it, it absolutely makes sense. But what I want to tell you about this really quickly before we move on is, remember earlier on, I said that a blunted first phase insulin response is one of the earliest predictors of type 1 diabetes because it influenced postprandial glucose levels. And I said, therefore, you want to be able to evaluate somebody's first phase insulin response, which is by looking at their postprandial glucose, essentially, to let you know if they have a first phase insulin response or not, which also says if somebody doesn't, okay, follow this backwards. If somebody has a high postprandial glucose response, you're probably lacking a first phase insulin response. You lack a first phase insulin response because you're not making enough GLP-1 incretins or stimulating them, okay? So this was that whole glycemic variability, lacking a first phase insulin response, too high excursions postprandially, causing more endothelial dysfunction, more oxidative stress, more damage. And this is the marker that can help you evaluate some of this. So let's talk about it. So here's just regular good old glucose, and here's this 1,5-anhydroglycitol. And you can see that molecularly, it's basically the same. I feel like it's a Sesame Street thing where you're like, which one of these is a little different? So it's lacking a hydroxyl group here, and because of that, it operates differently. It's in the food supply, we eat it, it's excreted, a whole bunch of things. It's not utilized though, because it's lacking that hydroxyl group. It's not utilized by the body in glucose biochemical pathways. And so it's not used, it's consumed, not used, and it's excreted. So you can go back, you can screenshot this, you can look at these, you can read these things, you can go back and watch this later, that's fine. But here's the bottom line. 1,5-anhydroglycitol is a marker of postprandial glucose excursions when glucose typically goes above 180 milligrams per deciliter postprandially. Now, that's not that high. I mean, that's kind of high glucose, but postprandially, when you start looking at some people's postprandial glucose markers, that's not that high. So it's a pretty good marker in people where it goes above 180. There's a little bit of gray area where if it doesn't go above 180, is it still accurate or not? And the question is that to some degree it is, but there's a little bit of nuances to this, which I'll explain to you. So the way that it basically works is, okay, I'll kind of try to explain this one. So when in a healthy, I'll put it this way, in a healthy individual, ready? In a healthy individual, you eat this 1,5-anhydroglycitol, you also have glucose. The kidney filters glucose, but then reabsorbs it. In somebody with hyperglycemia, it has so much glucose going through the kidneys that glucose wins for reabsorption and 1,5-anhydroglycitol does not. So you end up urinating out more 1,5-anhydroglycitol, which then what would that do to your serum levels is it would lower that. I'll say that all again. In people that have postprandial glucose excursions above 180 milligrams per deciliter, because there's so much glucose that reaches what's called a Tmax in the kidneys, transport maximum, is glucose wins. There's so much glucose being reabsorbed in the kidneys that 1,5-anhydroglycitol does not get reabsorbed and it loses. There's just not enough of it, and it gets excreted. Because you're excreting it, your serum levels go down. So the lower somebody's serum glycomark, or 1,5-anhydroglycitol, the higher their postprandial glucose excursions going. I'll say it one more time. The lower the serum 1,5-anhydroglycitol or glycomark goes, the higher their postprandial glucose, which is an indication of a blunted first phase insulin response, which is an indication possibly for GLP-1. Now, this is a table put up by the people that do glycomark, and you can see that the lower the glycomark, the higher the postprandial glucose excursions. Now, it depends on your practice if you're seeing severe diabetics and some of those things. I will tell you, I'll show you a different range that I have here. But once it starts to creep down below 15, you want to start being suspicious. There's a caveat to that, which I'll explain. So this glycomark tells you more than just A1C, and actually I have a better picture than this. And here's why, you guys. This is what I'm saying. So here's Mary and here's William. They both have an A1C of 7.4. Let's say they both have the exact same fasting glucose too. Here's the thing. Do you have a high fasting glucose A1C protocol? Most people probably do. But here's a big difference. Mary has an extremely low glycomark, and you can see because she has massive glycemic variability. William, on the other hand, has higher glucose than he should have, but it tends to be more stable. Now, when you look at this, do they get the same protocol? And the answer should be no, they shouldn't. Mary has glycemic variability. Mary seems to lack a first phase insulin response. Bill is just too much. He's probably, maybe, I don't know what his insulin levels are. He's probably making a little too much glucagon. He has too much hyperglycemia, that's fine. But this, and by the way, this again is a bigger problem. Mary has a bigger risk for cardiovascular disease and a whole bunch of issues because she has more glycemic variability. This is why I said the end of the A1C era, because really we should be considering this glycemic variability, because A1C does not tell the whole story by any means. That's why also we need c-peptide. So if you look at this list, I don't have references, and I apologize about this, but I don't really say many things unless it's justified by some kind of scientific study. But all these things are caused by glycemic variability, oxidative stress, hypoglycemic tendencies, inflammation, decreased heart rate variability in women for some reason, mood, depression, poor quality of life, etc. So what's the utility of glycomark? Well, it's superior, according to this paper, to hemoglobin A1C for predicting coronary artery disease in people with diabetes. It's not only correlated with basal insulin, but closely, this is exactly what I was saying, closely associated with early phase and first phase insulin secretion. Glycomark is a marker of glycemic variability, which is a marker of postprandial glucose levels, which is a marker of blunted first phase insulin response, which is a marker of lack of incretins. Okay, so here's the reference range. I think it should be greater than 15, but there's a big caveat to the guys, and this is super important right here. I have found over the years that the healthier the person, people following a paleo diet, they might have an artificial, like a false positive. It will look like a low glycomark, but it's not in fact a low glycomark. So it tends to be in just, it's a marker that you'd use. If you have a kind of a healthy population, don't run it. It won't be accurate. You get some false positives and you're gonna freak people out. If you have a regular group, standard American diet, you know, just eating kind of whatever, that's the utility of this marker, okay? So there's a couple markers for you. And now we're gonna just talk briefly. I'm gonna go super quick through this, but I wanna show you some pretty awesome stuff in fatty liver. And then we'll talk about how to put this together. So glucose dysregulation, the question really becomes why, who cares? Yeah, Alzheimer's, yeah, cardiovascular disease, but you guys listen, there is more glucose, there's more subtle glucose dysregulation going on than we're aware of, because we're not testing things like c-peptide with an optimal reference range. We're not looking at things like glycomark in people that should have that, glycemic variability. And the question then becomes is, how bad are people really if we're not looking at these things? And fatty liver, I'm going to tell you, it's epidemic. And I'm going to show you the papers on these things. This is a bigger problem than most people realize. And I'll do the too long didn't read. Here's the summary. Fatty liver is present in more people than you realize because the diagnostic criteria or abilities for it stink. They're awful. They're horrible. Most people just look at liver enzymes, AST, ALT, but I'll show you that those can be completely normal in somebody with full-blown fatty liver or even fatty liver with inflammation. And it is going unnoticed and unchecked. And as I said in the very beginning, people are treating for some of the sequelae of fatty liver, not knowing it's fatty liver. Probably there's a lot of causes of it, but you know, in our society, probably due to some kind of glucose dysregulation. Anyhow, first and foremost, it has a new name. We're not supposed to call it non-alcoholic fatty liver anymore. It's supposed to be called metabolic dysfunction associated fatty liver. So just a little update. It takes a while to kind of get these things out of the vernacular, but that's kind of the push right now. So are you seeing any patients with anxiety? Yeah, big yes to that. depression, yes. Cognitive decline, chronic pain, fatigue, poor detoxification. I'm going to tell you, it may all be due to fatty liver. Now, let me say that really closely again. Anxiety, depression, cognitive decline, you guys might be fatty liver. And AST and ALT will not show those to you necessarily. I promise you. I've seen this there's so many papers. I'll put it this way. There's so many papers where the inclusion criteria is fatty liver as diagnosed by ultrasound, and AST and ALT are in the low 20s. In all the thousands of people in these studies, AST and ALT will not show you fatty liver all the time. Okay. Anyhow, so anxiety and depression. So subclinical depression, subclinical anxiety, you guys, is real common. So check this out. Here's a paper that says subclinical and clinical depression was noted in subclinical depression was 53% of people with fatty liver. Subclinical anxiety was in 45%. Now that right there, we could just be done. Subclinical depression, subclinical anxiety, that's people with a little bit of blues, a little bit worried about things, a little bit maybe more than they should, not full blown, maybe not to need to be medicated, but are coming to you. And again, what do? We give them GABA, we give them 5-HTP, we give them tryptophan, or whatever kind of formula we want. But this might be coming from somewhere else. This might be coming from fatty liver. That's coming from some kind of unknown glycemic variability or glucose dysregulation that we're not evaluating well enough. Smaller brains. Listen, here's a couple of papers. Look at this. Besides fatigue, non-alcoholic fatty liver patients may also experience other symptoms such as anxiety and depression, cognitive impairment, and, believe it or not, loss of self-esteem. I mean, what else do you need to say? Check out this. Significantly influences cognitive deficits and tissue volume reduction, smaller brains. They had 4 times higher risk of having a cognitive impairment just from fatty liver. Your question should be, oh my gosh, which one of my patients who are talking about senior moments, who are talking about cognitive decline, I'm not thinking straight anymore, and you want to give them some acetylcholine kind of supplement or some neurostim or whatever, crazy brain supplements they have nowadays. Guys, if it's fatty liver, I'm sorry, those aren't going to do that much. Here's another one. Look at the title. Fatty liver disease with lower brain volume in healthy middle-aged adults. A smaller total cerebral brain volume in people with fatty liver, pointing to a possible link between hepatic steatosis and brain aging. And this is a big topic today, isn't it? Stop the neuroaging. Let's take, scutellaria and apigenin and all these flavonoids that have no human clinical trials. But what about fatty liver? What about finding that and treating that? Anyhow, it's not just the liver. Look at this. Complications of non-alcoholic fatty liver disease in extrahepatic organs. Now, it doesn't just affect the liver. This paper and papers are huge. Patients with non-alcoholic fatty liver have increased risk of end-stage liver disease, hepatocellular carcinoma, and liver-related mortality. Got it, but let's look at this. However, the largest cause of death among patients with fatty liver is cardiovascular disease, followed by extrahepatic non-liver malignancies. And they go on to say, extrahepatic complications include chronic kidney disease, extrahepatic malignancies such as colorectal cancer. You guys follow that? Fatty liver and colorectal cancer, psychological dysfunction, GERD, obstructive sleep apnea, periodontitis, hypothyroidism. That's kind of a big one today, right? Growth hormone deficiency, polycystic ovarian syndrome. And this paper goes on to basically say that it's not just a liver disease, but it's the underlying cause of an increasing number of extrahepatic manifestations. And look what it says, thus it should be treated as a multi-system disease. So let me get this straight. Liver dysfunction is associated with anxiety, depression, cognitive decline, poor self-esteem, chronic pain, fatigue, cardiovascular disease, cancer, poor detoxification, and that's not the worst part. The worst part is, as I said, lack of adequate diagnosis. So here's 5 reasons that fatty liver diagnosis really is buns, as my kids would say. Number 1, liver biopsy is considered to be the gold standard. However, consider that when you get a liver biopsy, you're only sampling 1/50,000th of the entire liver. And studies have shown that if you take one patch, even the neighboring patches from that might have different levels of fibrosis, histologically speaking, 40% of the time. If that weren't enough, pathologists can't even agree. So they take out some tissue, super invasive, by the way, big needle into your liver, takes some tissue out, they look at it. Pathologists can't even agree on the level of fibrosis or fatty liver that might be going on. So even the gold standard liver biopsy leaves a lot to be desired. 2 is you can't wait for ALT to decrease. I'm just going to show you a few things here. 79% of adults with fatty liver have normal ALT. I'm sorry, that's AST. 55% of adults with fatty liver have normal aminotransferases, that's both, and all these different papers. And 1/3 of the population, Hispanics, had fatty liver, but 79% had normal ALT. You guys, it will not go up. It does, in rare cases, it does. You have to look at it from an optimal reference range. If you wait for the lab range, you're gonna be missing fatty liver every day of the week. The entire histologic spectrum of fatty liver can be seen in, you can have normal ALT and have every single stage of fatty liver. Same deal. The histological spectrum in these individuals is not significantly different from those with elevated ALT. That's not helpful. And low normal ALT values does not guarantee freedom from underlying inflammation with fatty liver and advanced fibrosis. So you can't look at ALT, it doesn't work. These are the optimal ranges that I teach, and I think they're very accurate. Men and women should have different ranges. I'm telling you guys, if you start seeing them creep up into the 20s, and if somebody has sort of the, I don't know what you want to call it, not avatar, but the diet, lifestyle, and some glucose stuff, you want to strongly start considering that they might have fatty liver. Okay, number 3. So look at this: limitations of liver biopsy and non-invasive diagnostic tests. Fatty changes in the liver are generally diagnosed using imaging methods. However, sensitivity of those imaging techniques is low in cases of mild steatosis. So even things like ultrasound and CT scans are still going to miss things. This one starts to get a little bit scary because there are people that have, we tend to think that people with a higher BMI and, there's sort of a, like I said, an avatar for fatty liver, but it turns out, look at this, lean individuals may experience more severe hepatic consequences and higher mortality relative with a higher body mass index when they have fatty liver. And look at this, is even worse. They have, lean people have more severe histological presentation and higher mortality of fatty liver than people that have a higher BMI. There may be as many as 10 to 20% of lean individuals with this metabolic associated fatty liver disease, depending on the demographic. And you can see here, this is just a big study, systematic review, looking at a whole bunch of different prevalence, looking at using different methods and in different countries, but it exists in everybody to some degree. And the last one, so this was looking at alcoholic liver disease. It takes 10 years to progress from fatty liver to fibrosis to cirrhosis, okay, and that's bad, but look at this next slide. This process is silent and symptom-free. Okay, this is in an alcoholic drinking a bunch, going from healthy liver to full-blown liver failure. It can take 10 years, but it is symptom-free and it's silent, okay? Doesn't matter where you look, even in the UK, everywhere, it's not diagnosed. So there's a lot of people that have it, and I just showed you a whole bunch of symptoms: pain, anxiety, chronic fatigue, cognitive issues, brain volume. Anyhow, so this paper says that the ranks the most serious public health problems of our time. If we're not looking at it and we're just treating brain aging, or we're treating, we're just giving neurotransmitters for anxiety, depression, or brain aging, or cognitive issues, or the flavonoids, or all this weird stuff that people are doing. Okay, we need to be looking at this instead. So can you see a lot of people have it, is associated with numerous other diseases and symptoms which patients are likely seeking help for. Detecting it even in the early cases is really difficult. However, bringing this back, this is just one of the many physiological connections between glucose dysregulation and other physiological dysfunction, making it mandatory that we assess, do a better job of what we're doing. Okay, hang tight. Okay, I'm doing pretty well here because we're about at the end of our journey. So we're going to try to put some of this together, and I think there might be some time for questions. If you weren't here at the beginning, I encourage you guys to next week, maybe give yourself a reminder. I don't know if Evexia will send out a reminder about this too, but our website's coming out brand new. I mean, it is, I haven't been this excited about our business for a while. We do some great stuff. I'm just going to say, my wife and I, and we even involve our 6 kids. They give us feedback on a whole bunch of variety of things. But you want to check it out. And I say that because I've been doing this for 15, 20 years, teaching this level of stuff that has the ability to really help people. And I say all that because we're about to do this putting together part here. And I will tell you, this is not just for my practice, but because we have a mentorship program and because we have practitioners that are using this information, the testimonials are fantastic. Just to tell you real quickly, there was a guy, he was a chiropractor wanting to do functional medicine and was like struggling. He did a really expensive, another program, wasn't getting results, and was like depressed, guys. I don't know what to say. He was like, he was in tears. We were on a Zoom call and he was in tears. He's like, I don't know what I'm doing. He is a new practitioner. He has confidence. He's using this glucose stuff that I'm about to show you. And he's like, it's amazing and it works. And so it's not just me saying it. We have a lot of testimonials of people that are using what I'm about to show you. Okay, and there's a lot more of this where this came from. So here's the question: should we merely seek to decrease glucose? And if you've been along for this whole ride, first of all, God bless you for doing so. I know I'm talking fast and this is a lot, so I appreciate that. And number two, you should seriously question if we should, if you've been following this, because maybe not. And this is a slide that grossly needs to be updated. But what I did here is I put a bunch of things that are glucose lowering agents, and I put in some of their known mechanisms of action or supposed mechanisms of action. And what I highlighted in red, and look at these: gymnema, bitter melon, vanadium, holy basil, fenugreek, black cumin seed. Do those lower glucose? 1,000% they do. 1,000% you can give people. If there's anything we have in our herbal or botanical arsenal for something that has very consistent results, it's hypoglycemic agents. These things lower glucose. But my question is should we be? If it basically is acting like insulin, looking like insulin, stimulating insulin in the models that I just showed you. So based on that, let's take a look at this. Oh, and I did say, if studies have suggested that insulin resistance may be protective and increasing insulin is counterproductive and maybe even dangerous, should we be doing it with herbs? And I don't have the official answer because, quite honestly, there's no studies that I found looking at these herbs and causing any kind of negative effects in some of the things we looked at tonight. But what I can tell you is there are some solid things that we need to be doing first. I feel personally that we're in this very supplement heavy industry. We're not taking away supplements, we've been adding them. Think about 20 years ago, the number of supplements, even that one company would had 20 years ago. They started out with 1 or 2 supplements and now they have 100 or 200 supplements. I mean, it's more confusing. So why not use some things that we know that works, that have some studies behind them? Anyhow, hypocaloric diet, high protein, chewing your food, macronutrient sequencing, exercise. I'll show you a couple other things. So I don't need to go into hypocaloric diet. You know darn well eating less than we're supposed to be eating is one of the best methods from a dietary perspective on improving glucose regulation. Even if the diet itself doesn't improve, eating a little bit less tends to do that. There's a whole bunch of studies that suggest that. I put a very general rule of thumb to figure out somebody's calorie level is taking their body weight multiplied times about 9 or 10, just for a ballpark. Calorie counting leaves a lot to be desired, but you do need to start somewhere. So how about high protein? So check out this paper. It was a systematic review. In the summary, proof of concept studies showing that high protein diets have beneficial effects for glycemic control and type 2 diabetes without a detrimental effect on renal function and cardiovascular outcomes. There's not sufficient evidence to recommend one type of protein over another. And in this paper, anywhere from 30% of calories to as high as 62% of calories is used. However, protein intakes, according to this paper, recommendation in older adults are currently insufficient at only 0.8 grams per kilogram of body weight a day, despite many groups advocating for increased requirements of 1 to 2 in older adults and 1.2 to 1.5 in those who are at risk of malnutrition. So probably, I know the audience here, and you're probably using enough protein, but just to continue on that. In the absence of kidney issues, you can increase protein even more. I've done some presentation on this, which might improve satiety, protein synthesis, glucose regulation while keeping excess carbohydrates and fat in check from the diet. Carbs and fat can increase after a number of weeks after the initial low-calorie diet has been successfully followed. Chewing your food, yes, there's even studies on this. Check this out. Compared with 15 chews, 40 chews resulted in lower energy intake and postprandial ghrelin concentration. And here's our friend GLP-1, higher postprandial GLP-1 and cholecystokinin. So I'm not saying that chewing your food is going to have the same effects as Wegovy. However, if you're not chewing your food well enough, then you might not be getting the most from it. Macronutrient sequence. So this is a really cool paper. I'll just kind of show this to you. So what they did is they took people and they gave them fat, carbs, and protein, and they gave them to them either in different order entirely or in different combinations. And what I really liked about this paper was that, let's see, they showed insulin, and I think they even showed GLP-1. Yeah, so that's pretty good. So in this particular paper here, you can see that, and this is looking at change in glucose concentration depending on how they ate. And in general, eating, sorry, excuse me. Starting starting the meal with, this was vegetables, meat, and rice. Starting the meal with vegetables and then combining meat and rice. This was meat followed by vegetables and rice. This was vegetables, then meat, then rice, which is how some people eat. Then combining them all and then starting the meal with rice. And you can see the difference in glucose. Okay, but not only that, they also looked at insulin. So slightly different effects than insulin. Eating all of them mixed in together had a slightly better insulin response, but my favorite part was they actually ran GLP-1. And you can see here that combining everything together tend to have a lower GLP-1 response. Eating vegetables, then meat, then rice tend to have a higher. So is there a right way of eating? Not necessarily, but starting with the vegetables seems to have elicited a better response, and following with the rice. Anyhow, so I'll just take that for what it's worth. You don't want to start your meal with carbohydrates, which I think we all know, but we actually have some studies to back it up. So do you want to have a salad, or do you want to have a carb, wine and bread before your meal? I think you probably want to start with the salad. All right, so hypocaloric diet, we saw that. High protein, chewing your food, macronutrient sequencing, exercise. I'm just going to, I think I have one slide coming up here, or do I? I think it disappeared. Exercise, I will say, shoot, if I don't have it, let me say it now. There is no better glucose disposal agent than exercise. If you remember that party picture in that cell, exercise is what helps clean a lot of that up. Yeah, you can use things like carnitine and alpha-lipoic acid, there's some supplements, but ultimately, if you want to improve the health of the cell, improve the health of the mitochondria, there's nothing better. And you can say, well, what about cardio resistance training? According to the literature, they're both good for different reasons. Even for fatty liver, believe it or not, there's some papers showing that resistance training has certain effects on fatty liver. Cardio has certain other effects on fatty liver. So really, you should do both. It's not an either or thing. It's not like chocolate or vanilla. Both are going to be good. So I say this again because muscle contraction is the best glucose disposal agent that we have. I'm even going to argue better than insulin. Okay? Now, there's two more I have on here. Is what is a pre-meal protein shot? Again, this is not Ozempic or Wegovy. However, the studies are really cool on this. And this is basically showing, this paper looked at a variety of different things. Olive oil, whey protein, cheese and an egg, steamed mackerel, sounds good to me, grilled beef. So you can see here. And then how long they each ate it before the meal. And then what they looked at was the outcomes. And what I really want you to focus on, so you can look at glucose was suppressed, insulin was enhanced, but and again, I've been talking about it for a while. I know it's super popular now, but GLP-1. So if you want to, I'll slow this way down. If somebody has elevated postprandial glucose excursions, it's probably because they have a blunted first phase insulin response. It's probably because they're not making enough GLP-1. It's probably because they're not stimulating GLP-1. And what did we see? First of all, chew your darn food well enough. And second of all, have a and we just saw the macronutrient sequencing. Like this doesn't get any easier than this, is to have some kind of pre-meal, small amount protein. Fat turns out it's not bad, and there's even some things like digestion-resistant starches. The olive leaf extract's been shown to do this. I don't really like berberine long-term, but berberine's been shown to do it. Anyhow, so pre-meal shot is what we're calling it. Why? You get more GLP-1 and all the super benefits of that. There's a paper, look at this. Consuming a novel pre-meal whey protein shot of only 15 grams of protein before each main meal reduced the prevalence of daily hyperglycemia, thereby enabling a greater amount of time spent in euglycemic range per day over 7 days of free living in people with type 2 diabetes. So this is a proof of concept. A pre-meal protein shot, whey protein is usually used. Some people have a problem with that because of that. Pea protein's been used. I know olive oil sounds a little funny, like a tablespoon of olive oil, a scoop of some kind of protein powder. Digestion-resistant starches have been shown to do this pretty well as well. Olive leaf extract, kind of bitter, but that's probably why it works. But this, you guys, before a meal, where's the supplements? You don't even need them yet, okay? And then fiber. I'm not even going to talk about it, just to show you that this is an umbrella review. That's like beyond meta-analysis. This is a meta-analysis of meta-analysis. And I've done tons of presentations on fiber. And listen, you get fiber from vegetables and food and all that stuff. I'm telling you, I believe strongly this, and anybody with glucose dysregulation, or just about anybody, quite frankly, needs a supplement. They need a fiber supplement. I don't care if it's psyllium husk or something else more fancy by one of the professional companies, but they need a supplement because the number of things that fiber has been shown, I'll just put it this way. Show me the amount of human clinical trials on some of the weird supplements people are giving today. You can't, because they don't exist. Show me the number of human clinical trials on fiber. Okay, it's endless. And if we're claiming to do evidence-based medicine, which a lot of people like to say, you want the evidence? Fiber. There's evidence, beyond evidence, beyond evidence, and just about everything from Alzheimer's to glucose dysregulation to heart disease, you name it, fiber is right up there. If we're not recommending fiber, but we're recommending some weird supplement, we're not doing evidence-based medicine. It's my humble opinion. All right, so number one, oh, here's the exercise. Increase glucose utilization, encourage disposal. The best way to do it is exercise. Look at this. Exercise decreases intracellular NADH ratio. That's what created that crazy party, by the way. Increases GLUT4 translocation, supports insulin sensitivity, increases glucose intracellular utilization. That gets rid of glucose inside of a cell so that the cell can allow more glucose to get into the cell. This was looking specifically at resistance training. Again, just look at the bullet points. There's, again, if we're recommending weird supplements and all these things, and there's evidence based on for exercise and fiber, and we're not recommending those, we're not really doing evidence-based. All right, so how about if we increase GLP-1? Again, I feel funny to even have this darn slide here with all this discussion about GLP-1, but look at everything that it does: satiety, insulin, expressive glucan, all these things. Okay, now this is I don't have the references for this in the interest of time, but this is how much pea protein and EPA, DHA have been suggested to, in humans, increase GLP-1 as a stimulator. Berberine, I don't usually recommend it. Chewing food. Glutamine, you have to use an obscene amount. I wouldn't use that. Quercetin, I didn't have a dose. Fiber does it. Fiber, digestion-resistant starches tend to do it. Olive leaf extract, here's the thing. You want to feed as many birds with one seed as you can. So if somebody has gastrointestinal issues, they might have an infection of some kind, then listen, and they have glucose issues, then, you're in your pre-meal shot, use olive leaf extract. But if someone doesn't have anything to kill down there in their gut, then don't necessarily use it. And gluten, I'll just go ahead and say it. Gluten stimulates GLP-1. Okay, so if you're avoiding gluten, you might be you have more DPP4. So that's the connection. The more gluten you eat, the less DPP4 you have, the more GLP-1 you have. And I know there's a lot of people that are super anti-gluten still. I do have questions. I do have concerns about this whole gluten-free movement over the past decade or so, causing a whole bunch of glucose issues. Anyhow, so what if you have somebody with an elevated c-peptide? Well, if you go back to that party model, I suggest, and I have practitioners that have told me this works too, is mitochondrial support. And so exercise is a good way to support mitochondrial function, low carbohydrate diet, some of those things. But things like, make sure they're all on here. Yep, CoQ10, alpha lipoic acid. You can use acetyl-carnitine, but carnitine, look, it decreases ceramide synthesis. Creatine, the body makes all these things, makes it. Maybe somebody's not making enough of it. Vitamin E, so some of that oxidative stress that's going on. CoQ10, also mitochondrial, but oxidative stress as well. You want to promote some of the biochemical pathways utilizing some of the B vitamins. So if you look, so alpha lipoic acid is known, but if you get a chance, you guys look up CoQ10 and hyperglycemia, or L-carnitine and hyperglycemia, even creatine and hyperglycemia. I don't think we need to be giving some of these herbs that we're giving that are absolutely hypoglycemic agents, and they do work. But my question is how are they working? If somebody has high C-peptide, are they insulin resistant on purpose? What's happening inside the cell? If I go back to this, what's happening inside of the cell? Can we deal with some of this stuff by exercise, by supporting the mitochondria, by decreasing ceramides? And you don't have to give berberine, and you don't have to give gymnema, and you don't have to give fenugreek and all these things that I have questions about. Now, am I right about that? I have no idea, but it's just my thought. Low glycomark. Okay, we're coming up on the end here, guys. Wow, 2 hours. GLP-1 stimulators, we just talked about this. If somebody has low glycomark, and that's looking at maybe that they have glycemic variability and they're having excess postprandial glucose excursions, then you want to consider the things that we just talked about. Okay. So I think I made it. Anyhow, and understanding physiology is critical as a clinician, including we need to really take a good close look at the updated science. We need to be questioning paradigms that we're presented with because we've been wrong so many times before, and many times before, sorry, I just said that, and very often our understandings about things change based on the science. We have better, more accurate biomarkers and better reference ranges and how to interpret them than ever before, which I presented a couple tonight. And there's the better ranges. Also, why knowledge of glucose dysregulation is critical as it relates to other things. We talked about fatty liver. We could have talked about hormones. We could have talked about Alzheimer's. Evidence-based interventions, which I showed you for various patterns of biomarkers and better support healthy glucose. And then lastly is think of things on a cellular level, as well as whether the body is doing things intentionally and not forcing it to do something because we think it's a good idea. We've seen a lot of that stuff before. So anyhow, if you like this, if this helps you see more clearly, I want you guys to join us. Remember, this website, as it is right now, is going to change in about a week. You can visit it now, but things are going to change. Courses are going to change, offerings are going to change. So you can just make a note to check sometime next week. We'd love to have you. Our Clinicians Code Mentorship 6-month program, my wife and I run, has truly been more amazing than I could even begin to tell you over the years, and the number of practitioners that are still with us. So thank you so much. And I have the wrong slide in here for some reason. Anyhow, any questions? I'm going to turn it over to you.
Dr. Walsh, thank you. Amazing as always. You pack so much into your presentations. You take a little sip of water and let me just read through a few of these. And I know we always have Dr. Sedano with us as well. If we can just go back a little bit, there are several questions in a row related to NAFL. Could some folks with Alzheimer's actually be NAFL?
1000%.
Okay.
Yeah, no, listen, and so here's the whole part of that, and I hope that I got this across, is so glucose dysregulation is not the only way to have fatty liver. Lipopolysaccharides are a real quick way. Choline deficient diet is a real fast way, or methionine, basically not enough sulfur. There's a number of ways to it, but when you look at the causes like intestinal permeability, lipopolysaccharides, glucose dysregulation, and a choline deficient diet, which there's more choline deficiency in the diet than there is vitamin E or magnesium when you look at the studies. You know, there's a lot of people walking around with fatty liver. It is completely silent, even till end stages. I mean, when someone gets end stage liver disease, then and only then do they start making so much ammonia that it starts messing up their brain where they can't even think straight. And they start like, you know, it's also like it's Alzheimer's like symptoms, like they forget where they are when they're driving kind of thing. And so that whole time it's completely being missed. And I'll tell you, like, look at studies on people, the inclusion criteria is fatty liver diagnosed by ultrasound, and their ALT and AST is almost always in the 20s, which is well below the lab range. So we as a community, conventional and I will argue functional nutritional medicine community, are missing fatty liver every day of the week. And we are treating the sequelae of it, pain, chronic fatigue, or just fatigue, cognitive dysfunction, anxiety, depression, all these other things. So yes, I would say, I will not say that Alzheimer's is always fatty liver. However, there are some strong correlates between subclinical fatty liver or subclinical liver dysfunction and some of the same symptoms for Alzheimer's.
Thank you. So what is your approach to testing for fatty liver?
So there are, and it's way too deep to get into right now. There are about, I'm going to say 5 or 6 validated calculations that look at fatty liver. And the problem with them, so there's one called a fatty liver index. You can look that up. There's an Italian researcher, who's an amazing mathematician, turns out. The calculation required for it is beyond what a scientific calculator could even basically do. But basically, he took, it was GGT, waist circumference, and triglycerides, I believe. Maybe there was a 4th metric, maybe BMI. And basically, you run their calculations. And so what they'll do is they'll take, because fatty liver is so difficult, right? You can't do liver biopsy just about anywhere. You might be able to get an ultrasound, but it might miss things. Same with the CT scan. It's just too difficult to get. So there are a number of fatty liver calculations that each require different metrics. Some of them will look at insulin. Some of them will look at platelets. A lot of them will look at ALT, for example. So some of them will catch fatty liver depending on the person. That guy's fatty liver index, he's going to miss the lean ones all the time because he uses, I believe it's waist circumference and BMI. He'll miss the lean ones. And there are other ones, however, that are more likely to catch them. So that we know of today is some of these validated fatty liver calculations in the scientific literature. If you use more than one, then chances are you'll be best apt to find it of just about anybody else.
Thanks. Okay, how about this one? Can you discuss how glucose dysregulation plays a role in kidney disease and what someone would do when you can't increase dietary protein?
Yeah, so that's a big topic. So I was talking with a nurse, a conventional nurse at one of our seminars, gosh, so long ago. She worked in a kidney clinic, and she said, she was the first one that really tipped me off to some of this, that they start to see damage to the kidneys at an A1C of way lower than what's okay for most people, like 5.3 kind of thing. And that was really significant. Basically what it is it's similar to the retina. When you get down to I would say the capillary level and some of the, so the kidneys, I'm blanking on the term, sorry. The kidneys filter. Gosh, that was not a difficult word, but yet it was. They filter and reabsorb a lot. So with all that filtering and reabsorbing that goes on in the nephrons, in the tubules, I should say, it causes, there's such a rich supply of capillaries down there in the kidneys. Remember, they get something like 40% of our cardiac output. They get a massive amount of blood flow, and because of that, they get damaged more quickly than, say, something that gets less blood flow, like a skeletal muscle, for example. So that's really the mechanism, is they just get so much darn blood flow that they get more, because there's more glucose, they get an oxidative stress and glycated end products, so they end up at the capillary level get more damage. And then the second part of that is, I can't give any recommendations because there's different stages of chronic kidney disease and what people can use or not. But in those cases, we will very often use free-form amino acids, because if you look at the literature, and I don't recommend doing anything if there's some without justification, and I myself am not justification, go look it up if you're going to be doing things with patients. But look up free-form amino acid use with chronic kidney disease patients, because they actually say that it's justified, because you're getting the amino acids in sort of the pre-digested form, and you don't take a whole lot, right? You might only take, I don't know, 5 to 10 grams versus, a 20-gram meal of protein. And they get distributed. It's really interesting. They bypass splanchnic absorption, is what it's called, and go straight to the periphery, whereas protein digested as protein gets utilized a lot in the splanchnic circulatory system. So because of that, just look it up. But you can, I'll just put it this way: if I had chronic kidney disease, I would not hesitate taking free-form amino acids on an empty stomach as a way of supplying amino acids that the body needs in order to synthesize proteins, but not overburdening the kidneys. Oh, the second thing is look up the PRAL score, the PRA scale, the potential renal acid load score. You want to try to alkalize their diet as much as they can to try to conserve as much of the kidneys as they still have.
Thanks. Okay, just a few more we'll go with. Why is berberine not for long-term use, meaning long-term, like 6 months or longer?
Well, listen, yeah, okay, this is just me. I'm very rogue with a lot of things. A lot of people will disagree with. I disagree with what a lot of people say, and so then, and what's the justification? Is the fact that it's just so darn antimicrobial, and it's my concerns are mostly in the gastrointestinal tract. That historically we might take antimicrobial substances as spices, so like garlic might be mildly antimicrobial. Some of the bitters might have some mild antimicrobial activity, but we don't eat a whole heck of a lot of it. We might eat it as a culinary spice or in a dish, and we're not taking a concentrated amount of something that's really, berberine's potently. I mean, when you look at the mechanism like glucose regulation, it's amazing. Like berberine is, again, people compare it to metformin. It's It's phenomenal. It slows glucose absorption. It decreases gluconeogenesis. It seems to increase insulin dispose in the periphery. But it's so potently antimicrobial. I think our microbiome takes so much of a hit already for even mental emotional reasons, which is some pretty cool papers on that too. I don't think we should be messing with it too much. And so to take something that's potently antimicrobial for a long period of time, I personally don't think it's a smart idea. It works for glucose. I just think there are other things that we could take instead.
Okay. What are the optimal ranges for glycomark, and where can we see the optimal ranges that you have researched and determined?
So glycomark, it's above 15 is probably, that's really the cutoff. I told you before that that one's a little harder to come up with. I've gone through papers with that, and I presented it somewhere. Above 15 is kind of what you're shooting for, as long as somebody's following a standard American diet and their glucose is getting kind of high. If somebody's relatively healthy, I wouldn't bother running it. It's not going to tell you much. It might be false positive. So above 15, that's all I can tell you. And I teach a blood chemistry course that's available on our website. We have all the ranges. It's available as a download PDF for the ranges, but more than the ranges, remember, it's how to interpret these markers as a story. It's not just if something's high or low. It's the other markers that are high or low and the story that it presents. I wouldn't buy it right now, though, like I said, because we're flipping over the website mid next week, and so I would wait until that new website comes up.
Okay. Is GFR a better kidney marker than creatinine and BUN?
So yes and no. Okay, so you didn't say estimated. So actual GFR, yes, and that's where you go into a nephrologist's office and they'll run the glomerular filtration rate, and that is legitimate. The little e GFR on a blood chemistry is the estimated GFR, and that's a calculation based on age, gender. I think race goes into that, and then things like creatinine. So I'll put this real slowly. A normal GFR does not mean healthy kidneys. So just because someone's estimated GFR is normal does not in any way mean that there's normal kidney function. If GFR is low, should really raise an eyebrow though. So if you see a low GFR, if you're their practitioner, I would follow up with some kidney tests, which might be something as simple as just a urinalysis. Are they spilling protein? Are they spilling blood? And then if so, referring them out to a nephrologist or some kind of medical doctor is not a bad idea. BUN is not. I don't use kidneys. I don't use BUN and creatinine as a kidney marker very often because no, they're not very good. And I'll tell you why real quickly. So BUN is highly influenced by things like hydration status, protein intake, just a whole bunch of things. Creatinine is influenced. So this is a good one. Creatinine is influenced by muscle mass and also kidney excretion. So in the population, I could give you a quick quiz here if you wanted. Like what population, I won't really, because I don't want to embarrass you. What population is at the highest risk of kidney disease? Elderly, right? So the elderly but also have the lowest muscle mass. So they're going to have lower creatinine. In kidneys, they may not be working, which will increase creatinine and makes it look totally normal. And then the second piece is you can have somebody that only has one kidney that's had a kidney removed and they still have normal creatinine, normal BUN. So BUN and creatinine. So that's potentially another seminar, but kidneys never get caught until it's too late because you can have less than 50% function in both kidneys and still have normal creatinine. So just because BUN and creatinine and GFR are normal does not mean somebody has normal and healthy kidneys. So that's a long-winded way of saying no, I don't think they're great markers for kidneys.
Thanks, Dr. Walsh. All right, there's a few other questions that are more related to specific cases that we'll just get over to you, and you can follow up with the remaining questions. So let's just move to the next slide. If you don't mind, thank you so much. Just a reminder, everybody, Dr. Wayne Sedana, our Director of Clinical Support and Education, any help with lab interpretation, questions on clinical conditions, anything related to, differences in labs and the such, all of that, can be found under Ask the Doctor on the left-hand side of your Evexia portal. Email consultation is absolutely free, or you can sign up for a live consultation and connect with the Zoom meeting and have all your answers answered there. And then I think we just have one more slide to go. For any questions, please contact Evexia Diagnostics by email at info@evexiadiagnostics.com. We are here 5 days a week at our extended hours, 8 a.m. to 8 p.m. Eastern Standard Time. Thank you so much, Dr. Walsh and Dr. Sedano, for being on this informative presentation. A recording of this webinar will be available by email in the next few days. Just a reminder, everybody, to please check on Dr. Walsh's metabolicfitnesspro.com after a week or so. Thank you, everybody, for joining us for this webinar event. Until next time, from everyone at Evexia Diagnostics, stay healthy, stay safe, and we wish you all the best on your pathway to wellness. Good evening, everyone. Thanks again. Good night.